You may have seen people walking down the street talking to themselves, not aware that everyone else can hear them. They may be talking loudly about politics or religion or the government, but not in a way that makes sense. They are disheveled. They may be pushing a shopping cart. They may be wearing a coat in the middle of summer. They might come up to you, or they may try to avoid you. Some of these individuals live with a chronic psychotic disorder. They may be stabilized at their baseline or functioning as well as possible given their history. They may be refusing treatment. It takes people on average a year to seek treatment when they first start hearing voices or having bizarre perceptions. What do you think keeps them from getting help? Would you want to let somebody know that you had been hearing voices? Oh yeah, by the way, I started hearing somebody talking to me this morning and there was nobody there. What do you think's going on with me? You may have heard the old expression, time is brain. To me, this means time spent staying on medication helps to protect the brain. Every time a patient goes off their meds, they risk relapse and they have an increased chance of decreased functioning. Today we are going to talk about what symptoms people experience with psychotic disorders, when people are at risk of these disorders, and what mental status changes you can expect to see with psychotic disorders. We will next explain how development of the therapeutic relationship is different with affected individuals and talk about interventions for those experiencing hallucinations. We will look at evidence-based interventions and take the opportunity to apply the nursing process. Throughout our discussion, we will integrate the concept of cognition. The ability of patients to think is changed when a person experiences psychosis. If the psychosis is short-term, the person experiences altered perceptions of situations. This could affect how they think in the moment, but usually doesn't cause long-term cognitive deficits. A person who has had schizophrenia for several years, however, and spent much time off of medications, may experience significant cognitive processing issues. What is psychosis? We describe someone as experiencing psychosis when they describe abnormal or disturbing thoughts or feelings, or demonstrate behaviors of that nature. Here's an example. One night I admitted a patient who thought the FBI was spying on him through the wiring in his home. He had ripped out all the appliances and thrown them in the yard, torn out the carpet, and was trying to get at the wiring in the home when he was Baker-acted. A person can experience psychosis just from taking specific drugs. Back in the 1960s, people would think they could fly and would jump off buildings after they had taken LSD, which causes psychosis. Today, unfortunately, a person might take a street drug not knowing that it causes psychosis. Synthetic marijuana and flakka are two substances which lead to this effect. I have seen young people hospitalized after taking substances like these. I did not see these individuals return to their baseline. They presented more like head injury patients. I encourage you to Google substances that cause psychosis to learn more about this concern. People may also experience psychosis because of stroke or dehydration. They may have HIV-related encephalitis or some type of brain injury or delirium. Here are the diagnostic criteria for schizophrenia. First, notice that there are 5 criteria. These are the most common symptoms of the disease. To be diagnosed with schizophrenia, the person must have one of the first three symptoms: delusions, hallucinations, or disorganized speech. Additional symptoms include grossly disorganized behavior and negative symptoms, which I will go over soon. Notice that the person needs to display these first three symptoms, or delusions, hallucinations, and disorganized speech, for most of 1 month. Why is this? Before making a diagnosis of schizophrenia, the provider will assess the frequency, intensity, and duration of the symptoms. This keeps people who may have temporarily become sick or psychotic and experience a hallucination from being diagnosed with schizophrenia. Having specific symptoms indicates intensity, and having those symptoms for a month indicates duration. Another component assessed before making a diagnosis is how the individual is functioning. Employers will report changes in work performance. Parents might notice a sudden drop in grades at school. Parents and significant others might report changes in behavior or odd verbalizations, or report periods of looking off as if talking to someone. All of this affects the individual's ability to perform normal functions in school, at home, or at work. On this slide, you will see that symptoms must last 6 months. Here, we are looking at duration. A person can have symptoms of psychosis for a month or longer, and it may be related to another mental health or medical disorder. If the symptoms continue beyond 6 months and the other problems are ruled out, then schizophrenia could be diagnosed. There are two categories of symptoms used to describe schizophrenia: positive and negative. I don't know about you, but I don't see anything positive about any of these symptoms. It took me a few years to learn how they decided which symptoms were positive and which negative. I'll share that with you soon. Positive symptoms include delusions, hallucinations, and grossly disorganized thinking, speech, or behavior. Negative symptoms include flattened affect, withdrawal from social activities, and lack of volition, which means a lack of motivation. What makes the symptoms positive or negative? Positive means that something was added that wasn't there before. Negative means that something was taken away. I know someone who had full-range affect as an adolescent, joined activities, spoke rationally, had no evidence of hallucinations. He was diagnosed at about the age of 25. I saw him about 10 years ago. What I know was that he had delusions when he was diagnosed, and at the time I saw him, he had a flat affect. So something was taken away. Boy, I tell you, that is hard to see. Here's a list of the other DSM-5 diagnoses that are classified as psychotic disorders. One commonly seen diagnosis in the clinical setting is schizoaffective disorder. This means that basically they have schizophrenia, but they also have intervals in which they have significant mood disorder symptoms. Other people might have simply delusions. One patient we had at Psych had used Flakka and presented with psychosis. He probably had a diagnosis of substance-induced psychosis. I saw another patient when I was with students who stated he'd been found running around the Ocala National Forest area in a state of psychosis, talking a mile a minute. He was diagnosed with hyperthyroidism. He had a psychotic disorder due to a medical condition. What are the most important points I have covered so far? Pause the video and jot down your thoughts. One of the first things I have covered that you'll want to be sure you understand is the difference between positive and negative symptoms. I will review several important points during the Zoom session. This topic can be complex. Post your questions on the discussion board as you think of them. Several factors influence the development of schizophrenia. First, there's a genetic risk that increases the more closely you're related. Third-degree relatives have a 2% risk of having the disorder. As the degree of relationship increases, the risk increases. Yet 60% of schizophrenics have no family connection. We know that dopamine levels are higher in those with schizophrenia. The specific science behind this phenomenon has not been unraveled, but it has been studied extensively. Exposure to viruses and malnutrition contribute to susceptibility according to the National Institute of Mental Health. New studies are showing that there is too much pruning of the synapses in the brains of some persons with early onset schizophrenia. In studying brains of those with schizophrenia, we see a change in how the brain works. PET scans show that the frontal lobe has decreased blood flow, decreased use of blood glucose, and decreased use of oxygen. The frontal lobe is responsible for our higher level functioning. PET scans also show decreased volume in the hippocampus. Stress can make a person more vulnerable to schizophrenia. According to the stress diathesis model, if a person has a genetic tendency to have schizophrenia, then experiences severe stress, they are more likely to end up with schizophrenia. Imagine a person who has genetic susceptibility. They grow up and experience abuse, poverty, poor nutrition. They are taught only reactive coping skills and learn little in school. This person may be more susceptible. Several studies also show that in some individuals, marijuana use leads to psychosis. I get students every semester who send me articles making the opposite point. Because I have met patients who experienced long-term psychosis after marijuana use, I continue to follow the research on both sides of the issue. I encourage you to do the same. When are people first affected by this disorder? The youngest person I saw was 10 years old. He kept presenting with behavior problems, but one night he shared with me that he was afraid of the white transport vans outside the facility. He stated they were watching him. Next, he told me that computers were spying on him. The average age of onset is 15 to 25 for males and 25 to 35 for females. We had 2 to 3 young men a year who would come through our adolescent unit at Shands UF Psychiatric Hospital with acute psychosis. When someone has an early onset of symptoms, they're more likely to have long-term functioning problems. We try to get them to build trust early with the mental health system and to buy into the need for treatment or to understand why treatment is important. Many times when we hear the words schizophrenia, we might think of a person who screams out in public and makes no sense, who violates our boundaries and might likely be dangerous. Our perception may have come from the media. At any given time, most individuals with schizophrenia live in a manner that's not dangerous to the public. Many are homeless. Many live in group homes. Most prefer not to interact with us. One way to understand when a patient has a higher risk of misperceiving a situation and becoming more threatening is through understanding the stages listed on this slide. Those we are most careful with in psych are the persons in the acute stage. Let's look at these stages. The prodromal phase includes sleep disturbance, trouble concentrating, social withdrawal, earlier symptoms of psychosis, and problems functioning in school and at home. This phase may last 2 to 5 years. The acute stage symptoms include florid psychosis, so they're actively hallucinating and seeing things that are and having vivid hallucinations or vividly bizarre thoughts that they describe to you. They may have delusions, and these cause significant distress. This may be when they present as a danger to self or others. The number of acute phases a person experiences likely depends on their treatment adherence. In general, an increased number of acute stage untreated psychotic episodes is associated with poorer outcomes. The residual phase starts with stabilization. The person has regained control but is out of energy and is trying to deal with how they are affected by their condition. There's a second part of the residual phase called the maintenance phase, and in this phase they start functioning again. They complete goal-directed activities and may still have cognitive and negative symptoms. Schizophrenics live with stigma. They are isolated because they can't talk to people easily and share what they are experiencing, but they also face more physiological burdens than other individuals throughout the course of their lifetime. Because many live out on the street, they end up eating whatever is available. They do not usually make healthy food choices, but they are able to learn about healthy foods and make better choices based on their preferences. They are often not active, but they respond positively when programs are introduced into care facilities. They end up with higher rates of heart disease, diabetes, and metabolic syndrome. During the first year after their diagnosis, patients with schizophrenia are at their highest risk of attempting suicide. Be sure to read the Psychotic Disorders Pre-Assignment in Canvas, which reviews both the terms you learned in psychosocial assessment and offers new terms. I have emphasized how patients with schizophrenia are affected. Try to determine which behaviors, mannerisms, and types of speech you might see with positive symptoms and which you might see with negative symptoms. I have integrated the terms into the case studies and will also do this in class on Tuesday. Many of the terms are used to describe patients in the Psychiatric Mental Health Nurses Report and in provider documentation. Let's shift gears now and talk about hallucinations. Hallucinations are sensory perceptions experienced in the absence of an actual external stimulus. You can have a hallucination of any of the five senses. The most common type of hallucinations are auditory. 60% of persons with schizophrenia report hearing voices. Interestingly, 15% of individuals without schizophrenia also experience auditory hallucinations. With auditory hallucinations, individuals hear voices or sounds that don't exist or are misperceptions of inner thoughts and feelings. With visual hallucinations, they see persons, objects, or patterns that do not exist in the real world. With tactile hallucinations, they feel strange sensations on the skin when nothing is present to cause a sensation. This is common when patients experience delirium tremens, which you will learn about in the substance abuse lecture. Olfactory hallucinations occur when individuals smell odors that do not exist, and gustatory hallucinations occur when someone tastes something that does not exist. Here are 3 additional terms you will see related to schizophrenia. The first is illusion. This is a perception that occurs when a sensory stimulus is present but incorrectly perceived or misinterpreted, such as hearing the wind and thinking someone is crying. Everyone may occasionally experience an illusion. However, illusions are extraordinarily common in people suffering from schizophrenia. With derealization, persons report that the world around them seems unreal and strange. Objects appear larger or smaller. People seem unfamiliar or mechanical. With depersonalization, individuals report feeling as if they have lost their identity. They may feel that their body parts do not belong to them. They may also describe feeling as if they are in a movie. According to the psychiatric literature, symptoms of derealization and depersonalization start to occur before more severe mental illness. Imagine what it must feel like to experience these symptoms. Judgment and insight. Judgment. For many patients with psychosis, impaired judgment stems from their faulty perceptions. These misperceptions lead to actions based on a decreased ability to recognize dangers or not taking actions necessary to keep oneself healthy. For example, one day we were working with a patient who had a history of aggression. A nurse was encouraging him to take his medication, and he had become loud and was posturing, which means he was showing his muscles, leaning forward, his fists were clenched. A small-framed young woman, about 110 pounds in weight, started to walk towards him to tell him to shut the blankety blank up. I quickly escorted her back to her room to keep her safe. What type of judgment was she using? I thought it was very limited. The other patient could have hit her before we were able to intervene. I just want to add here, the patient that I was at first talking about, with aggression, did not harm anyone the entire time he was on the unit. He was loud, but we planned ahead to keep the patients and ourselves safe and still treat him with respect. Go ahead, pause the video, and read through the scenario here. Answer these questions now on the activity sheet. We will go through them together during the live session of class. 3 of our program concepts apply when we talk about individuals with schizophrenia: sensory perception, psychosocial functioning, and eventually cognition. Let's follow the picture on this slide to see how people are affected. Most people start on the left with normal functioning. They have their first acute episode, during which they experience either altered thought content, like delusions or disturbed sensory perceptions. These changes affect how they think and function. With treatment, they can return to functioning at their baseline. Here on our picture, this is what happens with the first 2 episodes. After the 3rd episode, we see that the person does not return to baseline functioning. even though their symptoms are controlled. Now they may have more difficulty communicating or making responsible daily decisions. The concept of sensory perception includes how we interpret our sensations. We know that a person can experience a hallucination of any of the five senses. Imagine that your patient perceives that voices are telling him or her the food is poisoned and hears voices stating people plan to harm him or her. The person stops eating and stops going out into the community. What are all the ways this person's functioning is and will be affected by these perceptions? It's also important to understand how schizophrenia affects cognition. Early in the disease process, the patient's likely to experience abnormal perceptions, which alter how they acquire information. Once treated, they will receive non-distorted messages. Problems with acquiring information will also likely affect processing, storage, and retrieval of information. I've met some patients who appeared to be afraid of memories and wondered if the patient's memories were tangled up with fears associated with their hallucinations or disturbing thought content. Long-term cognition problems occur, as we stated before, when patients stay off their medication for an extended period of time. The frontal lobe is affected as well as other areas. This slide just shows responsibilities of specific areas of the brain. I'll let you read that information off the slide. With schizophrenia, changes are often seen throughout the brain. More specific changes are often seen in the temporal lobe and the frontal cortex, possibly contributing to the symptoms of cognitive changes and auditory hallucinations. What data can you collect when you see that a patient is having difficulty with their intellectual processes? In addition to changes noted from your mental status exam, you will notice that they think concretely. Here's one example. The nurse might ask, "What brought you here?" Patients without cognition problems might answer, "My mood wasn't so great," or "I was having suicidal thoughts." A patient with schizophrenia whose cognition was affected might say, "The police. After all, the police did bring them into the hospital." This is a concrete answer. They're not demonstrating that they're able to abstractly put the situation in perspective and explain how the changes in their behavior led to their hospitalization. They do remember the police escort. Some patients with cognition problems are unable to follow two-step commands. If you ask them to complete a task that requires 2 to 3 steps, they might become confused and not realize where to start. For example, you might notice that their room is cluttered and say, "Let's move everything out of the way and get started." We need to break down the task. We could start with, "Let's pick up this paper. Now place it here." Finally, when we have patients with negative symptoms, we notice they have little or no motivation. We will provide and encourage group activities, or we may just encourage them to come sit with us out in the day room. On this slide, I've captured 2 more issues we want to assess in our patients with schizophrenia: how they've accomplished developmental tasks and how they are functioning. Many people with schizophrenia have not met their developmental tasks. Their disease process limits the way they communicate, their ability to achieve intimacy, and to be productive. We get a picture of what limits patient progress on developmental tasks when we look at their psychosocial functioning. Look at the scale I created. I have seen patients who have had no job for 20 years or since they can remember. The students and I met another patient who still practiced nursing. Some patients stay in contact with a few family members, yet others don't. Most do not report having intimate relationships. Additional questions we might want to ask include, can they directly communicate their needs to others? Can they pay their bills? How do they get food for themselves? Can they cook or get their own groceries? Do they know how to apply for a job and keep a job? Once they have a job, how do they get along with the other people working there? And are they able to stay focused on their work? Patients with schizophrenia have many problems which affect their socialization. One of these problems is sometimes called ego boundaries, which means they lack a clear sense of where their mind or body or influence ends and someone else's begins. They may think, for example, that the television is making reference to them. When this occurs, we say they are experiencing a delusion of reference. What are delusions of reference? Patients exhibiting this symptom might believe neutral comments carry personal messages directed at them. These perceived communications might come from the television, radio, or pedestrians out on the street. They often have a negative tone and may stem from objects or events with no basis in reality. Individuals with schizophrenia also have difficulty with proxemics and nonverbal processing. This affects their ability to understand when they have entered another person's space. Here's one example. A patient approaches a nurse and states, "You were there, out there with my car. You were there. Go tell Miss Mary." Miss Mary's a social worker. "You were there." The patient continues to get closer and closer to the staff member or nurse. The staff member attempts to create space and does not agree that they were in the location, but did agree to let Mary, the social worker, know the patient would like to speak to the patient. Imagine this is happening to you. The term ego boundaries is not used often now. You don't need to remember it, but be aware that patients have different needs for space. Most schizophrenics need 3 times as much space as we do in a social setting. So what that means is most of them are not going to do what this patient did. They're going to do the opposite. I've had many patients get up when I was too close to them and walk away from me. In my example on the last slide, when the patient continued to talk about the staff member being out there by the car, that patient was entering the staff member's space. What we see with most patients with schizophrenia is the opposite. These individuals require twice as much social distance to be comfortable. This slide is a little abstract. It's designed to capture research about this behavior demonstrated by patients with schizophrenia. The dark boxes represent affected patients and the distance they need. The lighter colored boxes are normal patients, or regular patients without schizophrenia. Notice the patients with schizophrenia need twice as much space. I've observed patients move to another table or go to another room if someone enters their social space. One of the most important things to remember about patients with schizophrenia is that they have trouble with trust. Some patients end up not even trusting family members. It's a big challenge for us in psych to build this trust with patients, yet we have psychiatric nurses and mental health techs who accomplish this on our units on a daily basis or throughout the patient's stay. We're going to talk about how you can build this trust, but first I want to ask you to think about what contributes to this lack of trust. Here are some factors. First, the patients come to us with suspicious thoughts. Next, patients are aware of the stigma that others have towards them. Finally, patients have issues communicating as a result of problems they have with thought processing and thought content. Finally, I want you to think about or go back and read your text because there are other ideas that they have in there that are going to demonstrate to you just how in-depth these problems are that patients have. And think about how that contributes to their lack of trust. On the next two slides, I have a list of nursing diagnoses. The first slide lists nursing diagnoses we might see in patients with positive symptoms of schizophrenia. Let's see if we can apply these to a few of the cases we have discussed. The 110-pound patient who approached the aggressive patient and made threats was at risk of injury. The guy who asked about the car seemed to be acutely confused. I would want to know more about his situation before assuming that, but he remained focused on that topic. Other patients have significant trouble communicating. They may describe a bizarre, complex, imagined theory of the universe using very logical terms, yet not take care of themselves in real life. They may use very disorganized speech we can't interpret. Still others have difficulty within the family system. On this slide, you will see diagnoses for patients with negative symptoms. Basically, we want to address issues they have with self-care, increase their connections with people, and help them to find engaging activities. Leading speakers in the field of schizophrenia state that one of the best ways to address negative symptoms is to provide activities for the patients. Let's go back to our patient in the case study. What nursing diagnosis would you give this patient?